This is Dr. Hessel, cardiovascular monitoring. This will be in two parts. I'm going to start with the first part, and there'll be a second part in a second podcast. This is your reading assignments that you're familiar with. There's some other resources that are noted on this slide. Basic cardiovascular monitoring includes basic non-invasive monitoring, which we reviewed in my previous podcast on basic monitoring. There's also some advanced non-invasive monitoring I'll touch on briefly, but mainly we're going to concentrate on invasive monitoring. The first part of this podcast will cover arterial lines and central venous lines, and the second podcast will cover pulmonary artery catheter, cardiac output, and echocardiography. I reviewed basic monitoring in the previous podcast. This includes, of course, arterial pressure, ECG, saturation, end-tidal CO2, and urine output. There's also some advanced non-invasive monitoring, which I'm not going to cover much here. One is pulse wave analysis. I'll mention this a little bit today. Transesophageal echo, which is a minimally invasive technique consisting of inserting a special probe in the esophagus that permits estimating cardiac output and function. We have this technology, and you can learn about it on our service. I'll also briefly touch upon fluid responsiveness, but this will be discussed in more detail by Dr. Rebel. So what I want to talk about mainly in this session is monitoring arterial pressure and central venous pressure. Arterial pressure can be measured non-invasively, which we've talked about before, and also by a method called a NexFin or ClearSight. This is a unique system in which a cuff is placed on the finger, and by a unique technology is able to reconstruct an arterial waveform and calculate arterial pressure. This shows the device. It is available in our hospital. I won't delve more into its use, but you'll be exposed to it. It's fairly accurate in patients with normal physiology, but in patients with deranged physiology, it's less accurate than an arterial line. So let's turn to the standard invasive monitor, which is the arterial line. There are many reasons why you would use an arterial line: to get an accurate blood pressure, to have second-to-second monitoring of blood pressure, which is important under certain circumstances as outlined here, for dysrhythmia analysis, to assess blood for blood gases, but also all other parameters. And you can use the waveform analysis, which we'll expand on in a few minutes. The indications for arterial lines are summarized on this slide. When you can obtain blood pressure by other reasons, by other methods, when you anticipate rapid changes, when you're going to use vasoactive infusions, when prompt control is important under certain circumstances, in patients with pulmonary dysfunction, and in a number of surgical procedures where arterial monitoring is particularly important, or blood gas monitoring. There are many components to arterial pressure. We tend to think of systolic, diastolic, and mean, but there are many other components that are relevant, and we won't spend time on discussing in detail, but you need to think about that. One of the important new applications of arterial pressure monitoring is waveform analysis, and it is used in two methods. One is to estimate stroke volume and thus cardiac output. This can be done with uncalibrated systems. It was initially developed by Edwards using the FlowTrack system, but now there are many other companies that make this device. It's not as accurate as the pulmonary artery catheter, but is reasonably accurate in stable patients. Another application is to assess volume responsiveness. This is due to the effect of positive pressure variation on arterial pressure, so-called respiratory variation. You all know that during positive pressure ventilation, there is a variation in systolic pressure. Both the systolic and the diastolic and the pulse pressure change with respiration. This can be expressed by pulse pressure variation, systolic pressure variation, stroke volume variation, or pleth variation. And it's calculated as the maximum minus the minimum divided by the average. Normal respiratory variation during mechanical ventilation with a tidal volume of about 8 milliliters per kilo is less than 5%. On the other hand, large variations with positive pressure variation predict a good responsive to a fluid bolus. And this has become a commonly used method to assess whether a patient needs volume. Unfortunately, it has many limitations. You have to have a good arterial trace. You have to have a stable cardiac rhythm. You cannot have any respiratory efforts on the part of the patient. It's influenced by tidal volume and PEEP. It's probably influenced by underlying conditions. And the difference between a positive and a negative result are rather small. There's 10% versus 15%. And finally, it hasn't well been studied prospectively. Now let's turn to some details about placing an arterial line. You have a number of choices. Which site to use, which side, whether you use an Allen's, how to set up a transducer, and how to do the cannulation. I'll just touch on a few points of this. There are many sites for placing arterial lines: radial, ulnar, brachial, axillary, femoral, dorsalis pedis, posterior tibial, superficial temporal, umbilical. The primary sites we use: first, radial; second choice, brachial; third choice, temporal. The radial has the advantage that it's relatively easy. Most of you are experienced with it, and there's low risk. The disadvantage is it's not a central line, and it's often not available to us. This is the technique that I suggest, using the 20-gauge Aero catheter. This has a guide wire with it. A pre-procedure Allen's test. We'll talk about this in a moment. Strict aseptic technique. Extend the wrist on an arm board. Consider use of ultrasound guidance. We'll expand on this a little bit in a moment. Avoid the through-to-through technique if possible. Suture in place. Use an antimicrobial patch. I personally recommend this, but it's not required at UK. And I recommend placing the special arm board that we have available behind the hand and the wrist to extend the wrist and avoid movement. Now, there's a lot of controversy about the Allen's test. The Allen's test is a way of assessing how good the radial artery supplies collateral flow to the wrist. And if it doesn't supply a good collateral, there's concern that if you occlude the radial artery, there could be ischemia. Now, Slogoff has criticized this more than 30 years ago because there were false positives and false negatives. But most authorities recommend that if you have time to do the test and there's an alternative site available, you ought to do it. Finally, I'd like to recommend, and it's not on this slide, but also check to make sure that the radial artery is supplying flow to the arm. Sometimes you can feel a pulse in the radial artery, but it's being transmitted retrograde from the ulnar artery. So occlude the ulnar artery and see if the pulse is still there. And do a reverse Allen's where you occlude both arteries and then release the ulna and see if that perfuses the hand. Again, there's controversy about the use of ultrasound for placing radial arteries. It's shown to improve performance of less experienced practitioners, and it's very useful in identifying the location of the femoral, brachial, and axillary arteries, and in identifying the radial artery proximal to the wrist. Perhaps it should be used routinely. However, it has disadvantages. You need the equipment. It may expose to increased risk of infection, and most importantly, one loses the skill. In skilled hands, not using ultrasound is faster and just as effective. So I recommend that you try to learn the skill of not using ultrasound. Brachial artery is my second choice. The advantage is it's a larger artery. It's more central than radial and is helpful when the Allen's is unsatisfactory or there are no radial artery pulses and in low output states. The limitation is there is poor collateral around the brachial artery, and thus the distal arm is at risk of ischemia. Therefore, one must carefully monitor post-op and obtain vascular surgery consult if you suspect problems. Again, strict aseptic technique. I recommend using ultrasound guidance on all of these. I use a 20-gauge, 10-centimeter pediatric IJ catheter kit. I enter the artery with the 20-gauge metal needle, then insert the curved guide wire, followed by the 20-gauge catheter. Consider conversion to an alternate site after 24 to 48 hours. The third choice is the femoral line. The advantages, it's away from the upper body where you may not have access to, especially during resuscitation maneuvers or CPR. It's relatively large and easy to obtain, and it is central. The disadvantages is increased risk of infection and the risk of hidden and uncontrollable hemorrhage, and that many patients have peripheral vascular disease. Again, strict aseptic technique. You should always use ultrasound guidance. I use a 16-gauge single lumen 20-gauge IJ catheter, and I convert to an alternate site after 24 to 48 hours. Next, I'd like to talk about the complications of arterial lines. Why is it important to know the complications? To assess risk-benefit, to know what to look for, to know what to prepare to manage, and to consider how you should go about to minimize these risks. First of all, most importantly, there's false information. The transducer could be miscalibrated or not zeroed. It could be in the wrong position. There's problems with ringing and dampening, which are a complex subject which we'll not discuss further today. Finally, there's a problem of proximal occlusive disease. Patients with peripheral vascular disease often have significant differences in the pressure in the two arms, and you should always use the arm with the higher pressure. There's also risk of thrombosis, ischemia, infection, etc. Now, infection, while often considered minimal, when placed in the same type of patients for the same duration of time, the incidence is similar to central venous lines. Therefore, I recommend that you use similar strict aseptic technique when inserting and monitoring these patients. Let's next turn to the topic of central venous lines. There's much useful information available from central venous lines. The central venous pressure can give clues to volume status, but remember the static number is not very reliable. It can estimate left atrial pressure, and it can be used, importantly, to assess RV and tricuspid valve function. You can get information from the venous wave. It can be used to detect or treat air embolism, and it can be used to administer sclerosing drugs, painful drugs, and ensure prompt and reliable infusion of drugs during CPR and cardiovascular drugs and infusion. It can be used to obtain blood samples for any test, for estimating CO2 and base excess, to estimate mixed venous saturation. It can be used to pass other lines. It can be used for venous access in patients that are difficult to access. It can be used to diagnose arrhythmias. And there's special purpose central lines for dialysis, chemotherapy, veno-venous bypass, and for analysis of waveforms. Analysis of the waveforms can be useful in detecting abnormal rhythms, tricuspid regurg, tricuspid stenosis, tamponade, and malposition of the tube. You all know about the venous waveforms, and I recommend that you remind yourself of these various normal waveforms and their significance, and the abnormal waveforms such as pathologic V waves. Now, venous pressure should normally be measured at neutral or end expiration. This is usually, if they're breathing spontaneously, the highest pressure, and with controlled ventilation, the lowest pressure. The zero reference portion, is usually the phlebostatic axis, which is the fourth intercostal space in the mid-axillary line. If they're in the supine position. If they're in the lateral position, the mid-spine or the mid-sternum. Another limitation is the idea that a central venous line is a good way of giving volume resuscitation. I think I'm missing a slide on this regard. But the commonly used central venous line is a 7 French 20 centimeter 3-lumen catheter. The largest lumen on this is a 16 gauge lumen. This sounds big, but because of its length, its flow is no better than a 20 gauge peripheral IV. So if you think a 20 gauge peripheral IV is adequate for volume resuscitation, then yes, a central line. But otherwise, you need to use a large central line for fluid resuscitation, such as a 7 French single lumen catheter, introducer, or a so-called HOG, or 12 French triple lumen catheter, or a so-called MAC catheter, something really large, but not just a 7 centimeter 3-lumen catheter. Well, there are a number of contraindications to central venous lines. There are a few absolutes and a few relative ones. When inserting lines, you have to decide what kind of catheter to use, what approach to use, and whether to use ultrasound guidance. There are many factors of how you choose which catheter. On this line, on this bottom here, I've listed some of the choices. This is the commonly one used, 16 gauge, the largest lumen. The Precept, which is a fiber optic catheter, which we rarely use. The MAC catheter, which has two very large ports, and the 12 French triple lumen, sometimes called a TROG, which has two very large ports. This is a picture of the MAC catheter. And unique is it has a large central catheter, which is 9 French, which may be used for passing PA catheters. But it also has a separate 12 gauge catheter on the side, which is useful for a volume line. Now, there are many approaches. The most common is, or I shouldn't say the most common, an old method was the anacubital or cephalic. It's rarely used now. The subclavian, which is commonly used by surgeons, less so nowadays. The internal jugular, which is the one most commonly used by anesthesiologists. And the external jugular, the femoral vein, and other approaches. There are many factors that influence the choice, which are summarized on this slide, including your experience. But ultimately, you should become experienced with all of them, so that should not be a limitation. The presence of coagulopathy, accessibility, ability to position the patient, future position of the patients, directness to the right atrium, and skin condition. Other factors include the presence of other lines, surgical plans, previous use, venous status, chest tubes, carotid disease, relative complications, patient comfort, etc. Also, we need to know about complications for the reasons I've already noted. These occur at 3 different points. The first is during insertion, and these are summarized here. The most important is arterial puncture, and most importantly, cannulation of an artery, which should never occur, pneumothorax, bleeding. During insertion, you can also have air emboli, cardiac arrhythmias, and other things listed on this slide. While indwelling, you can have thrombosis, thromboembolism, infections, arrhythmias, perforations, etc. And even during removal, there are risks of air emboli, catheter or guide wire emboli, hemorrhage, fistulas, contamination, and thromboembolism. A word about insertion, and you've already or will have a simulation and then many opportunities in real life to learn about this, so I'm not going to go into the details. I just want to highlight a few points. The first is, I think, very important preparation. The patient, if not intubated, should be on nasal oxygen. They need to have monitoring of all of these parameters. They should have a peripheral IV ahead of time if possible. If you're going to use an arterial line, it's ideal to place it ahead of time. You need to have a resuscitation equipment, and it needs to be done with strict aseptic technique and adequate anesthesia. You need to set up your monitor, the emergency equipment. Patient lines, have your equipment be aseptic. Check out your transducer. And most importantly, assign someone responsible for monitoring the patient while you are concentrating on inserting the lines. You will try to pay attention to the patients, but you'll be diverted, especially if you have some problems inserting the line, and you need someone else watching the patient while you're doing your procedure. This is why surgeons have anesthesiologists to watch their patients. The 3 important places that you need to become very proficient at are these 3 approaches. I'm going to talk mainly about, briefly about these. For subclavian, I prefer the left. For these 2 lines, for the subclavian, I prefer the left, and for the IJ, I prefer the right. But you can do both. One of the most serious complications of placing a central venous catheter is placing a larger than an 18-gauge catheter into the artery. When this occurs, it is associated with significant morbidity and mortality. It's usually due to operator error and is preventable, and one must be certain that the smaller catheter is well seated in a vein before inserting the dilator or larger catheter. Finally, relying on pulsation or color of the blood is not reliable, nor is ultrasound alone. Therefore, you must, in my opinion, measure the pressure in the catheter either with a pressure transducer or most easily with the Fabian test before proceeding. The Fabian test, sometimes called manometry, is a simple way of measuring the intravascular pressure to differentiate a vein from an artery. It was described by Judith Fabian, an anesthesiologist at Medical College of Virginia, almost 30 years ago. You simply attach a length of tubing to the catheter to the vessel and use it as a water. In my opinion, there are 4 critical steps. You must use a plastic catheter, not a metal needle. It must be fully inserted. It must aspirate readily. And finally, the level must fall. Not be static, but fall. It has been shown that if this happens and you simply pull it out, the incidence of serious complications is up to 50% and death up to 10%. Therefore, if you place a 7 French or larger catheter or dilator in an artery, do not pull it out and simply apply pressure, but instead call a vascular surgeon. Now, in the past, there has been debate about the use of ultrasound. At least for beginners, it's faster, fewer sticks, fewer complications, and many believe it should be a standard of care. Certainly, all practitioners who place central lines should learn how to use it expertly. The ASA standards say that it is required for placement of internal jugular vein catheters, and it is now required in our medical center. It's also helpful in placing subclavian and femoral central venous lines. But it requires skill and training. It does not completely prevent arterial complications. It must be used dynamically, in other words, throughout the cannulation process, not just before. In my opinion, you still should perform a Fabian test. I'm not confident that using ultrasound alone is satisfactory for preventing this problem, to prevent complications. And in my hands, I have difficulty using it for the subclavian approach, but that's because I'm not very experienced with it. Now, several views are available: a short axis, long axis, and oblique. You'll get lots of training. I can't go into this in detail. Each of them had advantages and limitations, but you should yearn to use, interpret, and apply all of them. Many of our faculty are experts in this, can teach you. The standard is a short axis view. This shows the approach and the view. Closer view, and the concern always is that the carotid artery often sits behind the internal jugular vein and is very useful. I don't have a picture of the oblique view, which has both the advantages and disadvantages of the two techniques. And that completes my presentation for the first part, and I'll then go to the second part on another podcast to talk about pulmonary artery catheters and cardiac output monitoring and echocardiography. Thank you.